Today we will try to learn the intercostal. We will learn intercostal spaces. Now, what is meant by intercostal space? Intercostal space means the space in between the ribs. Arbitrarily any rib. This is the first rib, this is the second rib. So this is intercostal space. Similarly, second, third, fourth, fifth, sixth, seventh, eighth, 9, 10, 11. There are 11 intercostal spaces. Okay, and we can find 9 spaces in front. Okay, clearly, and behind we can see there are 11 intercostal spaces, and the other 2 spaces are open in front. Now, why we are very much interested about knowing the anatomy of the intercostal space? Because these intercostal spaces contain some important muscles. We know there is, during respiration, what happens? We inhale or inspire, and there is, what happens? There is increment of all the diameters of the thoracic cavity. That is anteroposterior diameter, transverse diameter, and the vertical diameter. All these diameters are increased. And there are some, in your physiology, you will be learning, or you have already have some idea. I don't know whether you have got those ideas like the movement of respiration, respiratory muscles, and in anatomy you will also learn the movements of respiration. There are 3 types of movement. One is pump handle movement, the second one is bucket handle movement, and there is the third one is the piston type of movement of the diaphragm. So these are the movements by which the diameters of the thoracic cavity is increased. And within this intercostal space, we will get the muscles. Intercostal, in between, we can find here, there are some muscles we can have. The most superficial muscle is directed. The fibers are directed downwards, forwards, and medially. So most outside muscle is called external intercostal muscle. And this external intercostal muscle is the muscle of inspiration. When it contracts, the elevation of the ribs, there is elevation of the ribs, so the anteroposterior and the transverse diameter of different intercostal spaces are increased. And the next 2 muscles, that is internal intercostal muscle and most inside, that is the intercostal, is intimae. When they contract, the ribs actually there is elevation. So if those muscles contract, there is depression of the ribs. So during inspiration there is elevation, during expiration, after the inspiration we need the expiration, because that gas, that carbon dioxide gas which is accumulating, it is in our tissue, ultimately it is transported to the lung and ultimately it has to come out. So during expiration there should be retraction of the ribs. So that retraction of the ribs are caused caused by this internal intercostal muscle and intercostalis intimi muscle. Okay, so they are the muscles of expiration. Now, what is the extent of these intercostal spaces? Anteriorly, you can see the lateral margin of the sternum. Posteriorly, we can find lateral side of the body of the vertebra, thoracic vertebra. Okay. So, this is the extent. So, the muscle, any muscle, that is the external intercostal and internal intercostal muscle, they are extended from this area to the lateral side of the body of the thoracic vertebra. The superficial muscle, that is the external intercostal muscle, which we can see here. This one is the external intercostal muscle. This is the rib. Okay. So this is the which looks like a comma. Okay. You can see. And this is the depression of the rib, which is called the costal groove. And we can find this is the external intercostal muscle most outside. So this muscle is taking origin from the lower sharp border of the lower sharp border of the upper rib. It goes down and the fibers are, you can see that fibers are directed downwards, forwards and medially, and ultimately it is inserted over the outer lip of the upper border of the lower rib. Okay. Next, we can find next muscle, that is the internal intercostal muscle. The fibers are directed downwards, backwards and laterally. And it is taking origin from the costal groove. And it is inserted, costal groove of the upper lip, and it is inserted in the posterior lip of the upper border of the lower rib. Okay. And most inside we can find another muscle, that is the intercostalis intimi or innermost intercostal muscle, which is taking origin from the ridge just above the costal. This is the costal groove. Behind the costal groove there is a ridge from where this muscle is taking origin, and it is inserted over the posterior aspect of the upper border of the lower rib. And this is intercostalis, but internal intercostal, and this is the intercostalis intimi. And in between we are getting these neurovascular structures. These neurovascular structures are from above downwards. These are vein, artery and nerve, which is simply called VAN, van. In all the spaces you can find this relation, that is the relation of the vein, artery, nerve, which is called van, except in the first space. In the first space we will see nerve, artery and vein, that is in this space. And now we have to know what are the typical intercostal spaces. Typical means there are some similarity, common, they share the common similarities, so they are called typical. When we get some abnormality or atypical things in somebody, we can say this is atypical. So typical spaces are third to sixth space. Okay. This first space and second space is, they are not the typical, they are called the atypical spaces. From 3 third, fourth, fifth, sixth. Up. So these 3, 3rd, 4th, 5th and 6th spaces are called the typical intercostal space. Why? Actually, we know this vein artery nerve or the neurovascular structures which are present in between the internal intercostal and innermost intercostal, that is intercostalis intimi muscle. Okay. So when these neurovascular structures are limited only to these intercostal spaces, that means these nerves are limited, are within these intercostal spaces, those spaces are called typical. And in those spaces, they are not only limited within these spaces, but goes out of this place and it supplies somewhere else. Like we know the first intercostal nerve divides into major upper branch. First intercostal nerve is coming from here. We know what is intercostal nerve? It is nothing but the anterior rami or anterior division of the thoracic spinal nerves. Anterior nerve, the nerve is coming from the back, from the respective vertebral foramen, spinal nerve, first thoracic spinal nerve. Now it divides into ventral rami and dorsal rami. We are not concerned with the dorsal rami. So, that nerve, each nerve, spinal nerve divides into ventral rami and the dorsal rami. We are not concerned with the dorsal rami, but because it will supply the back muscles, we are concerned with the ventral rami. Okay, so ventral rami will come out, the spinal nerve will come out and it will divide into ventral, means anterior division, and dorsal rami, means dorsal division. So this first nerve is coming out and we are concerned with the ventral rami, ventral division. And now this ventral division is coming and again it divides into, this ventral division is again divided into the first thoracic nerve, first intercostal nerve, then ventral rami of the first thoracic nerve, which is called the first intercostal nerve, divides into major upper branch and minor lower branch. The upper branch, we know the formation of the brachial flexures, C5, C6, C7, C8, and that T1 is nothing but the major upper division of the T1. And the minor lower division will traverse this space. And it will come out after traversing. It has got typical course, and ultimately it will come out anteriorly. It will pierce the internal intercostal, external intercostal. That is here it becomes a membrane like, which is called anterior intercostal membrane. Now it will pierce there is a muscle which is covering the chest, that is the pectoralis major. Okay, and it will pierce, come out, it will come out and okay. So, that nerve is not only confined within this first space, it also supplies, it is going to the neck or upper extremity. It forms, it helps in formation of the brachial plexus, lower trunk. So it is not only confined to the chest, it is confined, also it is going to the neck, and ultimately it is coming out of the neck and it supplies the upper extremity. We know the formation of the, that is the ulnar nerve, which is contributed by C8 and T1. So that nerve is called, that nerve is atypical nerve, and the space should be called as atypical space. Now why the second space is also called the atypical? Because we have seen the intercostal brachial nerve. So when that nerve is coming out, then ventral rami is dividing into two. One is confined within the space and another is going down, and it is joining with the medial cutaneous nerve of the arm. We have seen in this body, that is intercostal brachial nerve. So from the intercostal space, second intercostal space, again it is joining with the nerve of the arm, medial cutaneous nerve of the arm. So it is not only confined within this space, rather it is also supplying the upper extremity. So that space is not typical. And sometimes we know a twig from the T2, it may join with C8 and T1 and it contributes in formation of the brachial plexus. Prefix, postfix type of, might be knowing. If you don't know, not only C5, C6, C7, C8, T1, sometimes T2 nerve may join, or sometimes C4 nerve may join. The lower part of the C4 may join. So that is prefixed, and when T2 is coming, it is called postfixed. So first and second, they are not typical, atypical, because the contents are not, the contents means nerve is also a content, vein artery nerve. Nerve is not confined to the first, not only confined to the first and second space, but they are rather going to the neck and or to the upper extremity. Now from seventh space, this is first, second, third, fourth, fifth, sixth. From 7th, 8th, 9, 10, 11, these nerves, they are coming out and ultimately they pierces. There is abdomen, you can imagine, the skin, superficial fascia, anterior abdominal wall, which is formed by the external oblique, internal oblique, transversus abdominis muscles, anterior abdominal muscles, and here also we will get two on one on either side, there is a rectus abdominis muscle. So this nerve actually not, they are supplying these spaces, but from there the twigs are coming out and they are supplying, these nerves are not only confined here but also supply the anterior abdominal muscles. Okay, so those nerves are called, that means the spaces from T7 to T11. 7, 8, 9, 10, 11, lower 5 intercostal nerves. They are supplying this intercostal space as well as they are supplying the abdomen. So they are called the thoraco-abdominal nerves. When we will dissect the rectus sheath, the dissection, we will perform the dissection of the rectus sheath. We will find the nerves are coming from the lateral side of the rectus sheath and they are entering, and ultimately they are traversing the whole the rectus muscle, coming out and ultimately coming out, piercing the anterior wall, piercing the superficial fascia and the skin. There is no deep fascia in abdomen. So we can inflate our abdomen. After the heavy lunch or heavy dinner or after having some invitation, it becomes bulged. So there is no deep fascia, but this muscles acts as a tough, like a bone. During any injury, it can prevent, it remains taut. So ultimately those nerves are coming out. So typical intercostal space and atypical intercostal space. Now we will see the slides. So you can see here the 3rd to 6 intercostal spaces, typical, everything it is also in your book. I want to impress, I want to clear your ideas. Okay, I am much more interested to see these figures, not this. Okay. Now you can see the vessels, and one by one, vein, then artery, then nerve. Now we already have some idea that here we can find the extent of the external intercostal muscle. You can see this is the external intercostal muscle. Okay, it is going up to this, up to the lateral side of the thoracic vertebra. It is coming, it is traversing the whole space, and near this is called, this is the rib and this is the costal cartilage. So this is called costochondral junction. This is called costochondral junction. Near the costochondral junction, what we can see, these muscle fibers, here up to this costochondral junction we can see the muscle fibers, and beyond this level, okay, from the costochondral junction to the lateral side of the sternum, this muscle becomes a membrane like. There is no muscle fiber. It is called anterior intercostal membrane. Okay. So from the costochondral junction, okay, from the costochondral junction, so this becomes a membrane like. This same muscle, external intercostal muscle, this becomes a membrane. So this is called anterior intercostal membrane. Similarly, in other slide, we can find this is the intercostal membrane. Okay, and you can see the direction of the fibers downwards, forwards and medially, as if you are putting your hand within the pocket. This will represent the fibers of external intercostal muscle. Downwards, forwards and medially. Again, external intercostal muscle, we can find origin, insertion, innervation. Innervation definitely not by the facial nerve. Facial nerve will never supply, or femoral nerve will never supply. Do you think the ulnar nerve will supply here? Then who will supply? It's a common sense. Very good. The intercostal nerves. And action is always elevation of the ribs. So it is for inspiration, muscle of inspiration. Similarly, we can find in this figure the next layer of muscle, that is the internal intercostal muscle. And here we can find, so this muscle is, you can see the fibers are downwards, backwards and laterally. Forwards, medially, and there at right angles to the direction of the fibers of the external intercostal. So fibers are downwards, backwards, laterally. Now what is the direction of the fiber of the internal intercostal? What is the direction of the fibers of internal intercostal? So we can find these are the direction of the fibers of internal intercostal. That means downwards, backwards, laterally. And what is the funny thing related to this muscle? You have seen the anterior intercostal membrane in external intercostal muscle. So this muscle will again compete. It will say only external intercostal muscle will have a membrane-like appearance. Why not me? Yes, that is also present in the posterior part. The muscle becomes membrane-like in the posterior part. From where? We know the rib has angle, posterior angle, anterior angle. So from the posterior angle onwards, this muscle becomes a membrane-like, and this membrane is called posterior intercostal membrane. So external intercostal muscle becomes membrane, which is called anterior intercostal membrane, from the costochondral junction onwards and up to the lateral limit of the sternum. And similarly, this muscle will again become membrane-like from the posterior angle of the rib up to the lateral border of the body of the thoracic vertebra. And it is continued with posterior layer of the superior costotransverse ligament. We know there are some costotransverse ligament, lateral costotransverse ligament and superior costotransverse ligament or posterior costotransverse ligament. Superior means it is going from one rib to the rib above. So that ligament has two laminae. One is posterior laminae towards me, that is the posterior laminae. Laminae means layers. It splits into two layers. One is posterior laminae, one is anterior laminae. The posterior laminae Posterior laminae is going back, anterior laminae is going anteriorly. So posterior laminae is continued with the external intercostal muscle and anterior laminae is continued with internal intercostal muscle or the intercostal membrane, posterior intercostal membrane. If you cannot remember it, or if you do not understand this one, okay, I will let you know afterwards, but this is not that much important. Okay. Now, this is internal intercostal muscle. And whether it is external or internal intercostal, they are present in all the spaces. Concerned with the innermost, the third layer, that is intercostalis intimi. You can find there are vacant spaces, absolutely vacant spaces in posteriorly and anteriorly. Okay, so in anterior part of the space and the posterior part of the space is vacant. That means this muscle is confined only in lateral 1/3 of the space, whether anterior 1/3 is empty and posterior 1/3 is empty. So this muscle is confined only in lateral 1/3 of the intercostal space. And again, this muscle is absent. This muscle is absent in first space. This internal intercostal muscle is absent in the first space, and sometimes it is absent in the second space. So these are the muscles, and there are also some muscles which takes origin from the sternum and they are inserted in the ribs, and that muscle is called, this is the view from the back. That back means I am looking from here. This is the sternum and the ribs. I am looking from here. So we can see the sternum here. Where is the sternum? Posterior surface of the manubrium, posterior surface of the body, xiphoid process. Okay. Okay, clear. So this muscle is taking origin from the sternum and they are inserted to the second, third, fourth, fifth, sixth. This is called sternocostalis muscle. Again, this is another intercostal muscle, sternocostalis. Another set of muscles we can see. This view is from the front. We can find there are some muscles in the lower intercostal space and on the posterior aspect from one rib to another ribs. So they are called, these muscles are called subcostalis. So this subcostalis, sternocostalis and intercostalis intimi, they are grouped as one group of muscle which is called transversus thoracis muscle. Transversus thoracis muscle. So transversus thoracis muscles contains, well, it comprises of Sternocostalis, subcostalis and intercostalis intimi. They are called transversus thoracic muscle. They are all the muscles of expiration because they will depress the ribs. Okay. Now we can see this num is coming out. This is the anterior or ventral rami and this is the dorsal rami. We are not concerned with the dorsal rami. We are concerned with the ventral rami. You can see it is coming out and it ultimately divides into anterior cutaneous nerve which has got lateral and medial divisions. On the lateral part, we are getting another branch which is becoming posterior anterior branch. And at the angle of the rib, there is lateral branch. This is the lateral branch coming out from this area. It is traversing the space and coming out from the lateral side. And this lateral branch is continued, okay, along with the main nerve, and it may join with the nerve, the main nerve, or it can come out as a single nerve. Most outside is the external intercostal, internal intercostal, then the intercostal is intimi. So the nerve is moving in between the intercostalis intimi and internal intercostal muscle, and ultimately it comes out. Okay, it pierces the anterior intercostal membrane and it comes out, and it has got lateral and medial division. This is very important clinical anatomy. You can see a syringe. It is inserted in the intercostal space. You know the upper part of the intercostal space is traversed by this vein, artery and nerve. So if I put the syringe through this area, okay, it may damage this nerve or it can affect this nerve, or during your insertion the patient will feel excruciating pain because you are damaging the nerve. So the needle should be placed in the lower part of the intercostal space. This is right and this is wrong. Collateral, yeah, collateral, we are not concerned with the main nerve. Actually, safely, we have to go through the middle. Okay. So, we should actually, the direction is upwards, medially. Actually, this is, we can see this is the lung and this is the pleura. The blue one is the pleura, the lower limit of the lung and lower limit of the pleura. Why this syringe is inserted in the pleural cavity? Can you have a common sense? we have to take out something out. Pleural fluid. When there is collection within the pleural cavity, what is called pleural effusion. Whether it is benign or malignant effusion, we can take out the fluid that has got both diagnostic and therapeutic effect. If there is a collection in the pleural cavity, then excruciating pain you can have. To relieve the patient, we have to take out that fluid, which is called paracentesis. Now, intercostal arteries. In the space, we can find there are two sets of arteries. One is anterior set and one is coming from the posterior aspect. This is the internal mammary artery or internal thoracic artery, which is present just lateral to the lateral border of the sternum, and this artery is coming from the subclavian artery, and this is aorta. This is the thoracic aorta, descending thoracic aorta, from where other sets of arteries are coming. So this is called the anterior intercostal artery, and it is coming from the aorta is called posterior intercostal arteries. And the posterior anterior arteries, from the posterior aspect and from anterior aspect, they are anastomosis. The anastomosing point is the costochondral junction. At the costochondral junction, the posterior set and anterior set, they anastomose with each other. Okay. So this is the first, second, third, fourth spaces. In lower toe spaces are open, so with no arteries are present in anterior aspect. So here is the internal mammary artery, from where two sets of arteries are coming out in each space. Now this internal thoracic artery, slide shota dekho to asche na. So it is coming from the anterior intercostal arteries are coming from internal thoracic artery, and each space we are getting two arteries. You can see there are two arteries are coming in from the internal thoracic artery. Okay, two arteries are coming in each space. Now this internal thoracic artery, actually second, third, fourth, fifth, sixth, in sixth space, it divides into two arteries. One is superior epigastric and musculophrenic. So from 7, 8 and 9 space, these anterior intercostal arteries are branches from the musculophrenic artery. From 1st to 6th space, they are the branches from the internal thoracic artery. And this internal thoracic artery, it is used in bypass surgery. It acts as a graft, arterial graft. I will show you the figure also. And in bypass surgery, either we can take a vein, long vein from the leg or from the thigh, that is the long saphenous vein, or we can choose this artery, right internal thoracic artery or left internal thoracic artery. So you may hear the term Rima-Lima bypass surgery. Don't think that Rima-Lima is very sweet for you. The term is not sweet for you. Rima means right internal mammary artery and Lima is left internal thoracic artery. So they are supplying these spaces, and this internal thoracic artery has several branches. Common sense. Here is the pericardium, so pericardiophrenik branches. Here is the sternum, sternal branches. Here is the, it can perforate, it can come out, and it can supply the breast, perforating branches. And it can divide into two branches, the musculophrenic and superior epigastric. So internal thoracic artery is very important, which we can see in this space. And from where we are getting the anterior intercostal arteries. And there is a mnemonic by which we can remember the branches of the internal thoracic artery. I will tell you later, not in the lecture. Okay, this is a very nice mnemonic by which you can remember all the branches, because internal thoracic artery, in many times it comes in your exam. You have to remember the branches, codes and branches. Now the posterior intercostal artery, you can see it is coming from the descending thoracic aorta, except first and second space, or even in the third space. I told you that is the posterior intercostal arteries are coming from the descending thoracic aorta. You can see from third, fourth, fifth, they are coming from the descending thoracic aorta. But the first one is coming from this artery. First and second, they are coming from this artery. Okay, or this artery. The same artery. Okay. This one. Or this one. So this is the aorta, this is the arch of aorta, which has got three branches: brachiocephalic trunk, left common carotid artery, and left subclavian. Okay. And this brachiocephalic artery divides into right subclavian and right common carotid artery. Now from this subclavian artery, which is continued as axillary artery, then it is continued as brachial artery, then it divides into radial and ulnar artery. So this, okay. Now from the subclavian arteries, we can see there are some branches are coming out. One is from the first part, vertebral artery, thyrocervical trunk, and internal thoracic artery, VIT. V means vertebral, I means internal thoracic artery. You can see it is coming down. Internal thoracic artery. And T is thyrocervical trunk. Okay. Okay. And from here we can see another branch from the first part or the second part. This artery or this artery is coming out. This is called costocervical trunk. C. Vitamin C, VIT-C. C means costocervical trunk. And another branch from the third part, that is the vitamin D, dorsal scapular. So vitamin C, D, if you can remember the branches of subclavian artery. So one of the branch you can see, that is the C, vitamin C, that is the costocervical trunk. From this costocervical, the word, within the word, you are getting the clue. Costo means costal space, cervical means in the neck. So it supplies the intercostal spaces, and also it is going to supply the neck, deep cervical or the transverse cervical artery. Okay, so this artery is costocervical. It is coming from the subclavian, and this artery divides into two, 1 and 2 branches, and they are entering into first and second space. So the first, the take home message is the first and the second artery, posterior intercostal artery, they are the branches of costocervical trunk, which is again a branch from the first or the second part of the subclavian artery. Subclavian artery is on the left side, is direct continuation, is a branch from the archa aorta. On the left side, brachiocephalic artery, which divides into right subclavian and right common carotid artery. So costocervical, costo mean costal space. So first and second posterior intercostal arteries are branch, or even the third might be a branch of branch from the costocervical trunk, which is a branch from the subclavian artery. This is a clinical one, that is in case of coarctation of aorta, there is obstruction of the aorta, there is rib notching is there, because this we know within the ribs in the costal groove we are getting the vein, artery and nerve. So if there is a pressure, if there is a distal obstruction, there will be increased pressure and there will be notching of ribs. The groove of the intercostal grooves will be more prominent, which is called notching of. Okay, you can see the rib notchings, arrow mark. Anterior, posterior. Now intercostal veins. Vein, artery, nerve. So veins have got similar course with the artery. Anterior will follow the anterior veins, anterior intercostal veins will follow, and it will drain into the internal thoracic artery. And posterior, they will go to the posterior aspect. Okay, they have got right-sided, right posterior intercostal, right posterior, left posterior intercostal veins. Okay, and they have got corresponding course with the arteries, but their drainage is unique. The anterior one is, okay, it is drained into the corresponding internal thoracic vein. Artery is there, corresponding vein is there. It is in anterior intercostal veins, it is draining. But you can find the posterior intercostal veins, first, second, third, fourth, fifth, up to the 11th space. So there are 11 posterior intercostal veins. The first, on either side, it drains into the, this trunk is called right brachiocephalic, this trunk is called left brachiocephalic trunk. They join to form this superior vena cava. And this brachiocephalic trunk are formed by the internal jugular vein and subclavian veins. This is right subclavian, this is left subclavian. So this is brachiocephalic and this is right brachiocephalic, this is left brachiocephalic, and we get the formation of the superior vena cava which opens within the right heart. Now you can find the first intercostal vein drains into the right brachiocephalic vein and left one drains into the left brachiocephalic vein. Okay. Now second, third and fourth, they joins to form right superior intercostal, and similarly the second, third and fourth joins to form left superior intercostal vein. On right side, this right superior intercostal vein drains into the arch of a great vein in the posterior thoracic wall. This is called azygos vein, which is absolutely transparent in your posterior thoracic wall. One vein which is azygos means A means single, zygos means this is not double, single. So in the posterior thoracic wall we will get a vein which is present in the posterior thoracic wall, which has got straight in course and it has got no corresponding arteries. So they are called the azygos vein. On the right side we will get the azygos vein. On left side there are two sets of vein, half of the which looks like half. Okay, so this is called hemiazygos vein and this is the accessory azygos vein. So from 5th onwards and up to 11th posterior intercostal veins, they drain into the azygos vein. Okay, whereas on the left side from 5, 6, 7, 8 they drains into accessory hemiazygos vein, and from 9, 10, 11 onwards, okay, they drain into this hemiazygos vein. Both hemiazygos and accessory azygos, they drain into this azygos vein, and this azygos vein ultimately drains into superior vena cava at the junction of extra and intrapericardial part of the heart. So these are the venous drainage or the posterior intercostal veins, anterior intercostal veins.